All right, class. Today we're continuing with pain management and moving into the second half of the topic. Last time, we finished up with opioids and the Pissarro sedation scale. Now we'll focus on everything that helps us support safe pain management. Respiratory assessment, naloxone use, co-analgesics, non-pharmacologic options, and the nurse's role in pulling it all together. Let's start with respiratory depression. This isn't just about counting a number on a monitor. Respiratory depression is based on what's normal for each patient. It becomes clinically significant when you see a decrease in the rate, depth, or regularity of respirations compared to their baseline. The risk is higher in older adults, people with obesity, sleep apnea, or chronic lung disease, and in post-surgical patients, especially during the first 24 hours after surgery or when they've received a high dose of opioids in a short period of time. When you assess, don't just look at the number. Watch the rise and fall of the chest. Pay attention to the pattern and listen to the sound of the breathing. Snoring is never normal in this situation. It means the airway is obstructed. Reposition the patient right away. Use a jaw thrust if needed, and don't hesitate to call for help if it doesn't resolve. If sedation becomes excessive and breathing slows, we use naloxone to reverse the effects. Naloxone should always be diluted, 0.4 milligrams mixed with 10 milliliters of normal saline, and then titrated slowly, about half a milliliter every 2 minutes, until the patient responds. The goal is to restore breathing, not to shock the person awake or send them into severe pain. Remember that naloxone wears off faster than most opioids, so the patient might need repeat doses or even a short infusion, especially if they've been on something long-acting like a fentanyl patch. Now let's move into co-analgesic medications. These are drugs that weren't designed specifically for pain, but can enhance comfort or treat specific types of pain, especially neuropathic pain. They include local anesthetics, anticonvulsants, antidepressants, and a few other agents like ketamine. Local anesthetics block sodium channels so the pain signals can't travel. They're used topically, by injection, or through nerve blocks. One common example is the Lidocaine 5% patch. It's placed over or near the painful area for 12 hours and then removed for 12. It's absorbed into the tissue right under the skin and produces minimal systemic effects. It's approved for post-herpetic neuralgia, but also works well for other neuropathic pain conditions. There are also newer liposomal local anesthetics like bupivacaine, which can be placed directly in a surgical incision for longer-lasting pain relief. Side effects are rare, but if the drug is absorbed systemically, early toxicity signs include a metallic taste, ringing in the ears, irritability, or numbness around the mouth. Cardiovascular effects can include bradycardia or arrhythmias, so always monitor closely when these drugs are infused. Anticonvulsant medications like gabapentin and pregabalin are also considered first-line treatments for neuropathic pain. They work by stabilizing nerve membranes and decreasing the transmission of abnormal impulses. You'll see these used for conditions like diabetic neuropathy or post-surgical nerve pain. They're even being added to multimodal post-op pain regimens to reduce opioid use. The main side effects are dizziness and sedation, especially when the dose is first increased, so start low and titrate slowly. Antidepressants can also help relieve pain. From a pain perspective, the most effective are the tricyclic antidepressants, like nortriptyline and desipramine, and the SNRIs, such as duloxetine and venlafaxine. They enhance serotonin and norepinephrine in the central nervous system, both of which help modulate pain signals. They're not used for acute pain because they take time to work, but they're helpful for chronic neuropathic pain. TCAs can cause dry mouth, constipation, weight gain, or dizziness, and they can worsen orthostatic hypotension, so use them cautiously in older adults. The SNRIs are usually better tolerated, but can still cause nausea, insomnia, or mild tremors. Ketamine is another unique option. It's a dissociative anesthetic that works at NMDA receptors, blocking the action of glutamate and preventing pain transmission. At low doses, ketamine provides analgesia without causing respiratory depression, which makes it especially useful in highly opioid-tolerant patients or when opioids can't be used. It can cause mild hallucinations or dreamlike effects, but these are minimized with low doses. It's given by IV most often, but can also be given orally intranasally, or subcutaneously. When caring for older adults, pain management becomes more complex. Many older patients live with chronic pain, but they're also more sensitive to medications that cause sedation or confusion, such as antidepressants, anticonvulsants, or opioids. For that reason, we always start low and titrate slowly. Acetaminophen is the safest first-line drug for mild pain, especially musculoskeletal pain like osteoarthritis. If an NSAID is needed, a COX-2 selective agent may be used, but with extreme caution because of the risk for gastrointestinal bleeding and cardiovascular events. Always pair NSAIDs with a proton pump inhibitor for gastric protection in high-risk patients. For opioid therapy, doses should generally start 25 to 50% lower than those used for younger adults. Now let's talk briefly about placebos. A placebo is any sham medication or procedure designed to have no therapeutic effect. Giving a saline injection or a subtherapeutic dose of morphine would both be considered placebos. It's only appropriate to use a placebo in research settings where informed consent has been given. It's never ethical to use a placebo to test whether a patient's pain is real. That practice is deceptive, violates trust, and can have serious ethical and legal consequences. Non-pharmacologic pain management is another important area of nursing practice. These methods complement medications rather than replace them. They're often most effective for mild to moderate pain or as part of a multimodal plan for more severe pain. They can promote relaxation, decrease stress, and give patients a sense of control. Examples include heat or cold therapy, massage, repositioning, relaxation breathing, guided imagery, music, prayer, and mindfulness. Movement-based methods like yoga or tai chi can also be beneficial if the patient is physically able. Some patients use biologic or energy-based therapies such as aromatherapy, herbal supplements, or Reiki. Our role is to support what's safe and evidence-based while assessing for possible interactions or risks. For instance, a patient using herbal supplements should be asked about all products they take so we can avoid drug interactions. When suggesting non-pharmacologic options, always consider the patient's ability and willingness to participate. If someone is exhausted or cognitively impaired, relaxation imagery might not be realistic, but a warm compress or gentle massage might help. Some interventions require a prescription in the hospital. For example, applying heat or cold for long periods can cause burns or frostbite. So check policy before you start. Finally, let's tie it all together with nursing implications for pain management. Optimal pain control requires teamwork. The nurse, the patient, the family, and the provider all share responsibility for creating a plan that's evidence-based and individualized. Our job is to assess thoroughly, document accurately, administer medications safely, and use non-drug measures to support comfort. We reassess at the peak effect of each intervention to evaluate both relief and side effects. If pain isn't controlled, we advocate for additional orders or adjustments. We also educate patients and families. They need to understand that pain management isn't just about eliminating all pain. It's about achieving a comfort function goal that allows the patient to rest, move, and participate in recovery. We teach them what to expect, how to report changes, how to manage side effects like constipation, and how to safely use medications at home. The expected outcomes are simple. The patient understands their plan, reports acceptable pain relief, participates in functional activities, tolerates medications without significant side effects, and expresses satisfaction with the care provided.